Welcome to today's Explainer. We're jumping right into a highly specific and honestly fascinating intersection of neurosurgery and general surgery. We're doing a granular point-by-point breakdown of two critical yet surprisingly overlooked issues with ventriculoperitoneal, or VP shunts. Specifically, we're looking at post-shunting skull deformities in infants, and then we're going to shift gears to the complex mechanics and risks of laparoscopic surgery in patients who already have these shunts. My goal here is to completely clear up these concepts for you step by step. Honestly, by the end of this, you won't even need to open your textbook.
To make sure we don't miss a single clinical detail, here's our roadmap. First, shunt-induced skull deformities. Second, the basics of laparoscopic insufflation. Third, mechanisms of increased ICP. Fourth, the risks of retrograde flow. And finally, prophylactic management.
All right, Section 1, shunt-induced skull deformities.
You know, it's pretty amazing just how dynamic a growing infant skull actually is. When a shunt rapidly changes the cerebrospinal fluid pressure, the skull adapts in real time. We've got a few explicitly documented structural changes here. First, there's an actual thickening and inward growth of the bone at the skull base and the cranial vault. Second, we see a measurable decrease in the size of the sella turcica. That's the little pocket where the pituitary gland sits. Third, a reduction in the size of the cranial foramina, which are those natural openings for nerves and blood vessels. And lastly, craniosynostosis, meaning the premature fusion of the skull bones. So what's the most prominent outcome of that premature fusion? Well, when the sagittal suture, the main seam running right down the top of the skull, fuses prematurely, it directly causes something called dolichocephaly. Simply put, the head becomes disproportionately long and narrow. When we're talking about post-shunting complications, dolichocephaly caused by sagittal synostosis is, hands down, the most common skull deformity you're going to encounter.
Now here's a really interesting number for you, 6%. You might naturally assume that dropping internal fluid pressure would routinely cause the whole head to shrink, right? But actually, microcephaly, where the head is noticeably smaller than expected, only makes up about 6% of all post-shunting skull deformities. And to tie that back to what we just talked about, roughly half of those specific microcephaly cases still involved sagittal synostosis anyway. But hey, the human body is incredibly resilient. It is fascinating to see that the skull maintains a remarkable degree of plasticity. These physical deformities we just covered, they can actually reverse themselves if intracranial hypertension or high brain pressure comes back. But there is a hard biological limit here. If the cranial bones have reached complete synostosis, meaning they are fully fused, that deformity is permanently locked in. It's not just going to undo itself, even under renewed pressure. Moving on to Section 2, Basics of Laparoscopic Insufflation.
Okay, let's look at the mechanics. To do a laparoscopy, general surgeons literally have to inflate the abdomen just to see what they're doing and create room for their tools. They pump carbon dioxide gas into the belly, creating what's called a pneumoperitoneum. Now, this is a completely standard surgical step, but as you'll see in a minute, it creates the perfect storm for potential shunt complications. That workspace pressure usually hovers right around 15 millimeters of mercury. If a patient is very thin, a lower pressure, maybe just 10 millimeters of mercury, might do the trick. But it is absolutely vital to remember that transient, sudden pressure spikes can, and do, happen. For instance, if a surgeon accidentally leans their weight on the patient's abdomen during the operation, that internal pressure is going to shoot up instantly. Which brings us to Section 3, Mechanisms of Increased ICP. There are 3 distinct mechanisms driving up intracranial pressure here, and we're breaking them down point by point. Mechanism 1 is basically just plumbing. When you inflate the abdomen with gas, that high pressure physically squeezes the vena cava. That's the massive vein returning blood to the heart. So this compression chokes off the venous return coming out of the head. It actually functions a lot like a Valsalva maneuver, when you hold your breath and bear down. And this drives up brain pressure completely independently of whether a VP shunt is even there. Now, mechanism 2 is biochemical. The body naturally absorbs some of that specific carbon dioxide gas right out of the peritoneum and into the bloodstream, raising arterial CO2 levels. High CO2 in the blood is a potent trigger that causes cerebral arterial dilation, meaning the blood vessels inside the brain literally swell and widen. Bigger blood vessels obviously take up more physical space inside that rigid skull, and boom, your intracranial pressure goes up. And finally, mechanism 3 is a direct mechanical block. The whole point of a VP shunt is to let cerebrospinal fluid drain downward from the brain into the abdomen. But if the abdomen is pumped full of high-pressure CO2, that fluid is now trying to flow down into a wall of high resistance. Naturally, drainage slows way down, leaving more fluid trapped up in the brain. Section 4. Risks of retrograde flow.
Let's put these numbers side by side so we can really understand the hardware limits. We know normal surgical pressures are low, right around 10 to 15 millimeters of mercury. But what about those severe pressure spikes? Well, in vitro testing tells us that extreme back pressures, specifically anything north of 80 millimeters of mercury, can physically break the shunt's delicate valve mechanism. If that valve gets blown out by a massive pressure spike, the shunt is going to completely malfunction long after the laparoscopy is over.
Then there's the nightmare scenario, retrograde flow. That's abdominal stuff flowing backward up into the brain. Thankfully, the shunt valve usually prevents this, keeping the risk pretty minimal up to about 80 millimeters of mercury. But it is not impossible. This is a crucial risk to keep in mind, because if a patient has peritonitis, sending infected fluid or surgical debris straight up into the brain is catastrophic. This danger is especially high if you're dealing with older valveless shunt systems, which are rare these days, but they're still out there.
Now, it's not all doom and gloom. Let's look at a pretty reassuring clinical insight. A fascinating case report actually used transcranial Doppler, or TCD monitoring, to watch a patient's brain blood flow live during a laparoscopy, and the monitor showed absolutely zero negative changes during the procedure, except during periods where the abdominal pressure spiked incredibly high. So this tells us that standard insufflation is generally tolerated just fine by the brain, as long as the surgical team is strictly preventing those severe spikes.
But even if the internal valve holds perfectly, surgeons still have to be hypervigilant about the distal catheter. That's the very tip of the tube sitting down in the abdomen. There's a very real mechanical risk of this tip getting occluded or clogged up by tiny air bubbles, loose surgical debris, or just shifting soft tissue during what is a very complex procedure.
Section 5. Prophylactic management options.
So how do we mitigate all this? Believe it or not, option 1 is to do absolutely nothing extra. I know, it sounds wild, and it is a highly controversial approach in the medical community. But some practitioners argue that since severe complications are actually quite rare when standard pressures are strictly maintained, adding special prophylactic interventions, which come with their own risks, might just not be strictly necessary.
If the team decides they do want to intervene, option 2 is temporarily blocking the shunt. They can do this in one of two ways. First, the general surgeon can clamp a hemoclip directly onto the catheter inside the belly. The downside? Well, they still need some initial insufflation just to get the camera in to apply the clip, and obviously they have to remember to take it off at the end. The other route is bringing in a neurosurgeon to temporarily externalize the shunt. That means literally pulling the draining tube out of the abdomen to drain outside the body. Sure, this completely solves the pressure problem, but it introduces a massive new drawback, a significantly higher risk of severe infection. Plus, the shunt has to be internalized all over again at the end.
Option 3 takes a more observational approach. Instead of pinching off the shunt, the team can place an ICP monitor directly on or in the patient to watch their brain pressure live during the surgery. This lets the general surgeon do their thing normally, but gives them a real-time warning to immediately vent the abdominal gas if that brain pressure starts climbing into the red zone. And finally, option 4. This requires a bit of compromise from the surgical team. They can simply mandate the use of low insufflation pressures, keeping that abdominal environment strictly under 10 millimeters of mercury. By doing this, the surgeons agree to operate with a much smaller physical workspace, but they safely prevent the dangerous pressure cascades and vena cava compression we talked about earlier. We have covered a ton of ground in this explainer, from cranial deformities all the way down to abdominal insufflation pressures. But I want to leave you with a critical, real-world clinical dilemma. Given the undeniable mechanical dangers of increased ICP, stacked against the severe, tangible infection risks of doing something like externalizing a shunt, how should a surgical team balance this controversial necessity? When the preventative measures themselves carry such severe risks, how do you decide the absolute safest path forward for your patient? Thanks for joining me today. Keep asking these tough questions, and I'll catch you next time.